in listen-only mode.
Good afternoon and welcome to today's webinar titled Anxiety and Autism. Today's presentation is being hosted by the Family Support Center of New Jersey along with Autism Family Services of New Jersey and presented by Dr. Rebecca Penna, a neuropsychologist with the Center for Neurological and Neurodevelopmental Health, also known as CNNH. While acknowledging the need for education around specific topics such as today's presentation, the Family Support Center of New Jersey also knows that families have many questions around their child's transition years. The Transition Matters website assists families and professionals in identifying resources to successfully transition your child or student with special needs to adult life. Resources such as webinars, in-person workshops, and statewide and regional contact information are made available on this site. We encourage you to explore this site for future sessions and to register for upcoming trainings. Before we begin, let's take a quick moment to go over how you can participate during today's web event. Everyone has their own control panel in the upper right corner of the screen that looks similar to the one here. Use the orange arrow to open or hide your control panel. To listen to the webinar, you have two audio options to choose from: mic and speakers and telephone. If you can't hear well using your computer speakers, you can elect to use your telephone to listen to today's session. In order to maintain the best sound quality possible, all but the presenter will be muted throughout the webinar. If you have questions or comments, you can submit them using the questions panel. All questions will be collected and answered at the end of the webinar as long as time allows. At this time, I would like to welcome Dr. Rebecca Penna. Rebecca, welcome.
Thank you so much.
And you should receive a notice on your screen to accept permission to show.
Yep, I did.
Perfect, thank you.
I'm going to pull this up. All right, hopefully you can all see my screen here. Thank you for that introduction. So I'm Rebecca Penna. I'm a pediatric neuropsychologist. I work at CNNH. And my background is in working with children, adolescents, and adults with a variety of neurological, neurodevelopmental issues. So we're specifically going to be talking about autism, and this is a population that I do work with quite frequently, again, from young children to all the way up to the transition age and into adulthood. I'm going to just explain very briefly about what CNNH is. CNNH it's a multidisciplinary practice, and we have several locations in the region, several in New Jersey, one in King of Prussia, Pennsylvania, which is where I'm located. It's a multidisciplinary practice where we have neurologists, neurodevelopmental pediatricians, and neuropsychologists such as myself we all work as a team to kind of understand what's underlying different conditions that affect children and adults. We also have a really nice and kind of multidisciplinary intervention team as well. We've got behavior specialists who do things like ABA. We've got folks available to do cognitive behavioral therapy, which is a form of talk-based therapy. We have a creative arts team, so folks who do music therapy and art therapy and dance and movement therapy, and we truly do try to work together to inform one another. And I'll just say briefly, you know, the philosophy that we carry here at CNNH and that I carry professionally is that it's really important to understand what is underlying a person's present condition. You know, what's really at the root of what's going on. This is important for us because we believe that in order to direct treatment appropriately, you need to know what you're targeting. So we take a comprehensive approach, and you'll see that today as I go through my talk. today's talk is going to kind of have three sections. I'm going to talk about autism, I'm going to talk about anxiety, and I'm going to talk about interventions or treatments to address some of these issues. But, you know, this is a very broad topic, very, very broad. Autism and anxiety is something that I think we could spend many webinar sessions to truly kind of get at all the different issues, because these things are very commonly co-occurring. So my intention today is to kind of provide an introduction around this as a topic, talk about some of the main elements that I think are important, and then depending on interest, you know, we can certainly talk about hosting another webinar session in the future if there's more specifics that we can get into. So when we take the broad overview approach, one of the things that we are trying to think about, from my perspective as a neuropsychologist, I'm thinking diagnostically in order to understand what's really going on. Are autism and anxiety separate things, or are they part of the same thing? And once we can kind of disentangle one from the other, if we can ever do that, how do we manage the issues that we see? How does anxiety manifest in children who have autism, and how do we move forward with our treatment? These are some of the things that I want to touch base on today. So, autism spectrum disorders. Autism spectrum disorder, or ASD, is the new diagnostic term that we use for what had previously been several separate diagnoses. With the change to the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, which is kind of the Bible, so to speak, of where diagnoses are described and that we then use in our practice, there was a change. So when we moved from the previous edition, the DSM-4, to DSM-5, several different diagnoses, related diagnoses, all got captured under one umbrella term, what we now call autism spectrum disorder. So it includes autistic disorder, Asperger's disorder, and PDD-NOS. All of these related diagnoses are now captured under the same term of ASD. As we all know, ASD is a spectrum. So, and the DSM-5 does a very good job. That's our newest edition, DSM-5, does a very good job of kind of talking about this, about the fact that autism, or ASD, really is a spectrum, and there are things about ASD that can fall more into the mild range to the severe range. And the related kind of terminology that you may hear of high functioning versus low functioning sort of relates to this idea of ASD as being a spectrum. But one of the things that we know is that the terms high functioning versus low functioning oftentimes are determined less by the autism characteristics themselves and are actually more kind of related to associated things such as language or intelligence level. Some of those characteristics tend to be taken into consideration when folks are making this determination, quote unquote, of high functioning versus low functioning. Regardless, we just want to understand that ASD is truly a spectrum, and in fact so is anxiety, which is something we'll talk about more in a moment. What is autism? What is ASD? Well, according to the DSM-5 diagnostic criteria, you have to have two things. There needs to be deficits in social communication skills, so some issues of socialization. That's part one. And part two is there needs to be the presence of restricted and repetitive behaviors and interests. So you have to have both of those features in order to qualify for a diagnosis of autism. If you don't have both of those features, there are other diagnoses that might capture, those symptoms. But when you do have both of those features present, you can qualify for a diagnosis of autism. So let's walk through a little bit what these diagnostic criteria really look like. So in the first area, this area of deficits of social communication, you have to meet in all three of these subsequent kind of qualifiers. So number one is deficits in social emotional reciprocity. This can look like a lot of different things, but here's some examples. Trouble with turn-taking in conversation. Trouble sharing when you're younger, being able to share your toys appropriately. Can range all the way to not initiating interactions whatsoever, so being extremely isolative and removed. So there's, again, this range of behaviors that can kind of all fall under this category of deficits in social emotional reciprocity. The second area here is deficits in nonverbal communication skills. So these are some of the things that we think of as being kind of those hallmark features that we see in autism. Poor eye contact, maybe having a limited range of facial expressions. So somebody who doesn't show the full range of smiles and anxiety and frowns and embarrassment or guilt, kind of those more nuanced facial expressions they may not show, to limited use of gestures. So not waving, not shaking hands when you get older, things like that. And then the third part is difficulties in social relationships. So you have to have some, those issues in your social skills have to manifest in some way with your actual social relationships with other people. And again, it can look very different depending on the person. Could be trouble adjusting your behavior to suit various social contexts, right? So knowing that it's okay to behave one way towards your parents than it is to behave towards your friends or your teachers or strangers. Not being able to kind of modulate your social behavior would fall under that category. It can range to having difficulty making friends, really wanting to have friends, but not having the tools or the ability to make friends very easily. And again, there's that kind of more severe, perhaps, presentation, which would be you just don't even have interest in your peers. You are, again, more socially isolative, just not very interested in socializing. So that's the first area, that deficits in social interactions. The second area that must be present in order for one to qualify for a diagnosis of autism or ASD, I do use those terms interchangeably, is you have to have this presence of restricted, repetitive patterns of behaviors and interests. And here you have to have 2 out of 4 options, essentially. So the first option is to have some stereotyped or repetitive motor movements, use of objects, or speech. And again, these are some of those hallmark features we tend to think of in individuals with autism. So hand flapping, perhaps lining up toys repetitively rather than using them as they're intended, and echolalia, or repeating words, scripting from television shows, repeating commercials, things like that, that tend to happen out of context and in a way that's not meaningful in a social context. The second option would be this insistence on sameness, routines, or rituals. And this is an important, a very important criteria for autism that really relates to anxiety, and we'll talk about this more in a moment. But the way this can manifest is you may have a lot of difficulty with transition. You may need to have very consistent routines that have to happen the same way every single day, and if there's a break from that routine, it can cause marked distress. Could be something like you need to take the same route home from school, and if you know, if that particular day you decide to go a different direction because you need to go to the grocery store, or you know, for whatever reason, that's not the regular way that the child knows you normally go home, and that can cause distress. Or needing to eat the same foods, so having a very selective range of foods and preferences, and not tolerating any introduction of something new to what's, you know, known and consistent. And then another example is a greeting ritual. So a child who might need to come into the classroom and say hello to every single person in the classroom, and it has to kind of be the same call and response every single time. Third area is restricted interests, so having preoccupations with unusual objects, for example, having just a fascination with toilets or ceiling fans or other things that are not typically of interest for a child, to having what's called circumscribed interests, meaning it is kind of a typical interest, but the extent to which the child is interested in that topic goes above and beyond what we would typically see. So maybe the child really likes Pokemon, which a lot of children really like Pokemon, but this particular child really only likes Pokemon, or can only talk about Pokemon, or you know, has to wear clothing, all has to have Pokemon, and if you try to add something different, you know, that's not agreeable to the child. So it becomes a very, very narrowed interest, even though it might be something that other children would be interested in as well. And then the fourth criteria that falls under these restricted repetitive patterns of behavior is sensory differences. So being hyper or hypo-reactive to sensory input. And again, this can look different. So for some children, they might be indifferent to pain, which can be very problematic if there's a child who doesn't really kind of respond to pain that they've experienced, physical pain that they've experienced, in a way that they might communicate to somebody else. You know, the parent may never know if the child's actually hurting unless they, you know, are showing more obvious signs. Adverse response to specific sounds and sights. So, you know, if they happen to see some kind of some sensory stimuli in their environment that the child has an idiosyncratic reaction to. So, for example, does not like to see men with beards, and if they happen to see a man with a beard, causes the child to have marked distress in response to seeing that. That's an example that falls under that category. And then there could just be a lot of sensory seeking behavior. So looking to smell or touch different objects and people as well. Sometimes it can cause a lot of social problems if the child is interested in kind of seeking that sensory input in a way that maybe crosses appropriate personal boundaries. So other parts to the diagnostic criteria, symptoms must be present in the early developmental period. What's a really important distinction that's been made to DSM-5 is that we now recognize that symptoms of autism may not really show up until the child's actually a little bit older. It used to be that the cutoff was 3. There had to have been presence of symptoms by age 3. But now we know that this can sometimes not actually be the case. You may not notice some of these issues until the social demands exceed the child's capacity. And the example we give here is a child who played pretty well with other children when he was a preschooler starts to have difficulty when he gets older because he has this restricted interest that really other kids don't share. You know, this is maybe, for example, a 10, 12-year-old who has a very intense interest in trains. And when he was younger, maybe that was typical. Everybody liked Thomas the Tank when they were younger. But now other children have moved on from that. He still remains very much fixated with that interest, and it starts to get in his way of kind of maintaining friendships. And then, of course, these symptoms have to cause impairment in daily life in some regard, and we also have to make sure that these symptoms are not better explained by something like an intellectual disability or global developmental delay, although both of those conditions can co-occur with autism. We just have to make sure that they're not entirely explained by autism. All right, so switching gears a little bit to talk about anxiety. So anxiety, we'll go through what some of the kind of diagnostic issues are with anxiety, but conceptually, the way we think about anxiety is kind of a triad of interacting components. Anxiety has thoughts, physical sensations, and behaviors. And so anxiety can show up one way or another, kind of more or less, depending on the person and on their age. In adults, we tend to see, or I should say, we can recognize anxious thoughts a little bit better because adults can articulate and verbalize what's going on. But that would be the worries, you know, the what ifs. Oh, gee, what if I don't do well, you know, on this test or on my job performance? Fears, I'm really afraid of what might happen if I leave my house, you know, and that's an example of agoraphobia. Physical sensations that are associated with anxiety can range, be a lot of different things, but some of the ones that we might recognize are shortness of breath, feeling like you've got butterflies in your stomach, rapid heartbeats, sweaty palms, things like that. Behaviorally, anxiety can look like a lot of different things as well, but it could look like restlessness, so you're not able to feel settled, you're not able to feel calm, or avoidance, right? You may just avoid whatever it is that causes you anxiety in the first place. And in my experience, what we have to be very careful to attend to in young children and in children who have autism who maybe are not as adept at being able to explain what's going on verbally is the behaviors. We have to be very, very good detectives, if you will, at trying to understand the behaviors we see in children and in children who have autism and how that might actually be a manifestation of anxiety or something else, but we really do have to attend to what those behaviors look like. So anxiety, of course, goes back to this very issue of the fight or flight stress response. That's essentially what anxiety is. So the stress response, the fight or flight stress response, is controlled by the autonomic nervous system in our bodies, which is part of, you know, it's part of our brain's system, okay, that helps to regulate all of these kinds of your internal organs, your bodily functions, things that you're not consciously aware of. But it's things like heart rate, respiratory rate, digestion. All of these are things that in response to a stressor get activated in some way or another. So the autonomic nervous system kicks into gear when one is encountering a stressful event, and that is essentially what anxiety is. It's a very ancient and adaptive system, right? It's one that has we have maintained evolutionarily. It was something in our ancestors and that we see in primates and in other mammals that really it serves to preserve life, the autonomic nervous system kicks into gear when there is either a real or a perceived stressor in your environment that could potentially be life-threatening. So, thinking back to caveman days, if you saw a snake come into your cave, that snake could be poisonous, that snake could harm you, could kill you. Your autonomic nervous system, your fight or flight response, kicks into gear in response to seeing that snake so that you can either run away or, chop it or do whatever you would do in order to kind of eliminate the snake as a potential life-threatening stimulus in your environment. So, nowadays I think many of us can attest that we still have some of those fears. I personally am not a very big fan of tarantulas or other spiders, and things like that continue to serve as stimuli that trigger our very ancient fight or flight stress response. But it's not just things that could legitimately cause us harm. It's all we perceive cause. Whatever in our environment perceived as a threat kicks this autonomic nervous system fight or flight response into gear. So again, it's very important for us to be attending to the behaviors and how this might actually look in a person. Might look like angry, very upset, maybe lashing out at other people because it's become so stressful and overwhelming that one cannot literally control that kind of fight response. Being very easily teary, running away, withdrawing, becoming even more and more isolative as a protective mechanism, a way to kind of feel safe and removed from whatever it is that's causing you stress. We can also look at some of those physiological sensations, particularly in older children, adolescents, those who have verbal ability, those who are able to kind of provide some insight into their own condition. But we can talk about, if we're trying to help build a sense of connecting one's behaviors with one's emotions, we'll try to use those physiological sensations as a way to do so. How does your body feel at these times? Do you have butterflies in your stomach? Do you feel a tightness in your chest? And use these other physiological examples that can be quite concrete as a way to build insight, build awareness, to start to gain eventually some control over your fight or flight response. So what is this relationship between autism and anxiety? And it's very complex, as I said at the beginning. And the way I think about it is it can kind of be understood along 3 dimensions. Anxiety can be understood as part of autism, as truly being inherent to what the features of autism are. It can occur secondarily to autism, or it can be distinct, meaning it's a co-occurring issue that isn't directly related to autism, but may be just as important that we address in our treatment, maybe even more so than addressing some of the autism symptoms. And we'll go through this to kind of understand it. Anxiety is part of autism. So we talked a little bit earlier about these restricted repetitive behaviors and interests, and in some regard, these restricted repetitive behaviors and interests can serve a self-soothing function. They literally can help to alleviate anxiety. They're done to soothe an overactive nervous system. From some examples that we have listed here, motor mannerisms, right, hand flapping, other kind of complex motor mannerisms like spinning or walking while jerking may actually increase at times of stress. You may see that increase in these behaviors during times of increased stress. as a way to kind of compensate for that stress. Sensory behaviors. The individual may seek out additional sensory input, or they may seek out specific type of sensory input in order to, as I said, kind of calm or counteract the overactivity of the central nervous system. And a good example of that, if you're familiar with the work of Temple Grandin, she developed the hug machine as a way when she was very overwhelmed by a chaotic day, that things were just a little bit beyond her capability to manage, this device that essentially served to provide deep pressure and kind of a squeezing sensation helped to calm her. It just helped to calm down that anxiety that had occurred. And then the rituals and routines that we talked about, as in some individuals who have autism have an incredibly high need for sameness and need for ritual. And it's this need for sameness and predictability that functionally is done in order for that person to feel safe and in control, right? It's to be an individual who has autism, you are constantly being faced with demands and expectations in a social world, in a complex sensory overload kind of environment. And needing these rituals, needing this predictability really does allow the individual to say, hey, there is something in this world that I have some control over, right? I'm not constantly out of control and in a place where I don't know what to expect. So this can be very helpful. I mean, it can unfortunately get to the point where they become so rigid that they cause significant functional impairment. But having routines and having predictability is a good thing for everybody, and particularly I think serves an important function to alleviate anxiety in individuals who do have autism. So now let's talk for a moment about how anxiety can occur secondarily to autism. So the first bullet is what I kind of just mentioned. Child with autism is constantly being confronted with things they don't inherently understand in a social world. And we live in a social world. Everything about what we do is done in some form of communication, some form of interaction with other people. I should say almost all things, but in order to really function and get along in the world, you absolutely need to have access to and be a part of a social world. This is in itself very stressful for a person with autism because they don't have the skill set. They don't have the skill set to be effective. So this can lead to chronic stress, and we do see this, children who just feel chronically stressed out that they just don't fit in and they just don't understand what's being asked of them. Relatedly, the second bullet describes the adolescent, so somebody who's a little bit older and maybe is that, quote, higher functioning young man or young woman, sees that her peers can make and keep friends easily. She really wants friends, has that social interest, but doesn't, again, have the skill set to be able to do so successfully. She really doesn't want to stand out as being different, and this causes anxiety, this idea of what's wrong with me, why can't I fit in, why is it so much harder for me than for my friends or for my peers. And then we have anxiety as being distinct from autism. So this is when you have actually a separate and co-occurring diagnosis. So the way we think about this is sometimes we need to differentially diagnose autism from an anxiety disorder because there can be such overlap. For example, social anxiety disorder. That's an individual who who does have appropriate social skills can do quite well socially, but is very, very fearful of having to be in the public eye, of having to interact with other people. And so that's an important distinction that we sometimes have to do a very good job, very careful job at looking to differentially diagnose, targeting treatment correctly. And it could look very different in somebody who has autism versus social anxiety disorder, even though they may look kind of the same out in the real world, right? They're both kind of reticent and hesitant to interact with other people. The other thing that can happen is, rather than having to differentiate these two issues, is that we have to look at whether they're co-occurring. So anxiety disorders do co-occur with autism all the time. And again, as we just itself, sometimes it's occurring because of autism, but sometimes there's a just entirely separate and distinct anxiety disorder that is co-occurring. Example might be generalized anxiety disorder co-occurring with autism. Generalized anxiety disorder being, having kind of pervasive worries about things that are range from, the news to safety to the dark to being alone to being separated from one's family, just all different aspects of what can cause somebody anxiety come up for the person. So sometimes these two issues do co-occur. And here are some other examples of actual DSM-5 anxiety disorder diagnoses that we have to think about when we're trying to understand what's going on. And there's a full range, as you can see here, from separation anxiety disorder, selective mutism. Specific phobia would be something like a specific fear of dogs or of lightning. Social anxiety disorder, which we talked about, panic disorder, so being prone to having panic attacks, right, which is when you suddenly and sometimes for unknown reasons just feel like you might die, honestly, because your heart starts beating so very fast and you can't breathe, and it can last for a few minutes and can just be very debilitating. Agoraphobia is a fear of leaving the home. Well, actually, it's truly a fear of public places, and so what ends up happening is the individual really doesn't leave the home. And then generalized anxiety disorder, which we just spoke about. There's some related disorders related to anxiety that in DSM-5 have been separated out, so they're no longer kind of part of the chapter on anxiety disorders specifically, but we know that these related disorders have a high anxiety is a high component of them. So that would be things like obsessive compulsive and related disorders. And then trauma or stressor-related disorders, so PTSD and adjustment disorders and things of that nature. This is just a brief slide here looking at kind of the comorbidities. So what does comorbidities mean? It just means the rates of co-occurrence between these two conditions. So we see there's pretty wide range of rates of co-occurrence, and that's because of just differences in how research studies are conducted, how they define these diagnoses, what procedures they use. But in some cases, we can see very high rates, specific phobias, giving a comorbidity estimate of 10 to 64% of individuals with autism also having a specific phobia. Again, that could be anything from like dogs to snakes to needles is a good example. Other specific things in the environment that could cause a person to have anxiety. So, and this final bullet on this slide is important. I think, as I kind of alluded to earlier, sometimes it can be easier to identify and kind of accurately assess the scope of an anxiety disorder in a quote, high-functioning individual with autism because they have the ability to verbalize and talk about what's going on, to be able to provide some insight into their worries, so we don't have to necessarily just deduce from their behavior. I put this slide in just because, you know, as I kind of said at the very beginning of this talk, it's really important to take a comprehensive view of what's going on with a person, and to not just narrowly focus on autism itself, because oftentimes it's the co-occurring or the comorbid issues that are causing sometimes more impairment, or that are causing the issues that really need treatment. And of course, there's good and effective treatments for autism as well, but it is my belief, and the belief at CNNH, that we really need to look at everything that's going on. So we see, you know, intellectual disabilities, what was formerly termed as mental retardation. Comorbidity estimates range from 20 to 70%. So that's, again, and the reasons why it varies is because of the way that past research studies have measured what would be an intellectual disability, and the samples that they used. So we do have a wide range, but so going all the way up to 70%, I mean, that's a very high, I think that's on the very, very high end of what the comorbidity truly is. But it's important to understand a person's cognitive level. That's to give an example, if somebody has an intellectual disability or not, maybe they have a language disorder, right? They have trouble comprehending language or producing language. If they are being put into a circumstance where the demands exceed their capacity, that can cause anxiety, right? If they're being asked to perform in a classroom where they don't really understand the nature of what is being presented to them instructionally, or if they're being asked to answer questions or in some other way express and communicate verbally, but they don't really have good language abilities to do so, that can be frustrating, first of all, but can also cause anxiety and kind of how do I navigate this situation? Oftentimes it's that discrepancy between ability and expectation that causes the frustration that then drives significant behavior problems, acting out behavior, aggression, rage, those kinds of things. The rates of co-occurrence of ADHD is kind of unknown at this point because prior edition of DSM did not allow us to make a comorbid diagnosis of ADHD and autism, even though those of us working clinically know that they co-occur all the time. But we don't have, unfortunately, good data on the rates of ADHD and autism, but that's another important area that sometimes needs to be addressed. And again, if the child is having a significant hyperactivity or impulsivity and it is not able to function in a classroom very easily because of that, right? They're maybe being reprimanded frequently because they're not able to sit still, or you know, they shout out rather than raising their hand. And the child feels badly because they want to be able to do well. They want to be able to get good recognition in the classroom, but if they can't do so because they have ADHD, that can cause anxiety as well. That can certainly contribute to anxiety. All right, so in our last couple of minutes, I'm going to just kind of talk briefly about what some treatments for anxiety in autism can look like. And certainly we can pursue this line of discussion at during another webinar if you all would be interested in it. But basics kind of overview of how we might treat anxiety in autism. The first thing is we have to actually know what version we're dealing with. Are we dealing with anxiety as part of autism, as secondary, or as distinct? The reason why is because different treatment approaches will be more or less efficacious depending upon which of those three options we're dealing with. Medication, for example, can be very effective in treating anxiety as a separate clinical entity, but anxiety that's occurring as part of autism may or may not respond quite as well to medication management. Sometimes there's success, but I think it really, it may be maybe that you might need to use more behavioral approaches if that's what you're dealing with. Psychotherapy, so the evidence-based approach to psychotherapy called cognitive behavioral therapy can be very, very effective for treating anxiety, both as a separate entity as well as part of autism, if the individual is verbal enough, is old enough, has the insight enough around their ability to talk about what's going on with them, what their experiences are, if they're able to kind of reflect on past experiences and then problem solve and think about how they might use new skills in new situations. So it does require a certain level of insight and kind of ability to reflect. Environmental modifications, this is a very important thing that we are always kind of talking about and can become increasingly important for our younger children as well as individuals who have autism who are also nonverbal or who have an intellectual disability who maybe wouldn't be able to do some of the talk-based therapy like CBT or cognitive behavioral therapy. But this can be really, really helpful, and it's very important, and it gets back to this idea of letting the child feel like they are in a safe, comfortable, predictable environment where they know what to expect, where they know what is expected of them. This can tremendously decrease anxiety, and it's that consistency and predictability that we work on with, establishing kind of daily routines, making sure that there's a lot of visuals in the child's environment so that they can recognize and readily understand the information that's around them. Occupational therapy can be really helpful for addressing sensory issues. So occupational therapists can help the child, the family, the teachers learn some strategies to self-soothe. So brushing techniques or weighted vests, other things that can maybe provide some additional sensory input or specific type of sensory input that does help to kind of regulate that nervous system can be invaluable, absolutely. And then social skills training. This is important in our population of working with people with autism. If we can help that person to develop better social skills in general, but specifically develop what we think of as social cognition, or the ability to think about social situations, the ability to engage in social problem solving. How would you handle this situation? What could you do differently? What do you think this other person might be thinking? Right? So kind of helping to develop a sense of theory of mind and the ability to engage in perspective taking. If we can work on building those skills, it's going to allow the person to become more effective in their social interactions. And then you have the downstream effect, right? So now they're more effective socially. So that means they're going to be more successful, and those opportunities and experiences of success are going to lead to a related decrease in anxiety in those social situations. So that can be also a very important avenue of treatment. All right, so at that point I think I'm going to stop there. I've kind of given the overview and talked about the issues I wanted to present to you all today in discussing what is autism, what is anxiety, how are these things interrelated, and what are some treatments that we can pursue. So thank you very much for your attention.
Dr. Penna, thank you so much. We greatly appreciate you sharing all this information. We do have quite a few questions coming in. The first one is, what is the difference between anxiety and excitability?
Anxiety and excitability. Well, I think that one way I might approach responding to that question is this. So I think that they're probably both related to the same type of physiology. So I think that anxiety and kind of quote-unquote excitability probably both relate to having that kind of overactive autonomic nervous system, if you will. I think that the difference is that one causes a degree of distress. Anxiety causes some level of distress, either in the person or in those around him if the person doesn't have the insight to understand what's going on with them. Whereas excitability could potentially be what we would call egosyntonic, meaning it could actually just feel good. It could feel good to get excited about things, and it could feel potentially pleasurable to kind of be one who is easily activated and aroused. So I think that that might be one way to make the distinction, but I do think they're probably physiologically related.
Thank you so much. And what medications can be used other than antidepressants for sleeping issues and anxiety? And how can the residual drowsy effects be avoided?
Okay, so medications for anxiety and sleep issues?
Yes.
Okay, yes, and then residual issues of somnolence.
How they can, how the residual drowsy effects can be avoided.
Yeah, okay. Well, so that's a good question, and I think that, you know, so my background is not as a medical doctor, right? I'm a psychologist, so I can't probably give the most specific answer to this particular question, but I'm going to give you some input based off of my experience in working with this population. So what we know is that so antidepressants, right, is one of those first-line treatments for managing anxiety, but there's definitely a full range. There's lots and lots of different medications that people can try and do try for management of anxiety. So it may be, if there's anxiety and sleep issues going on, it may be that it's not the right medication for that particular child or person, and that there may need to be discussion of what are some other medications that are available. There's, you know, as I said, there's antidepressants, which can chemically be a number of different things. There's selective serotonin reuptake inhibitors. There's the related SNRIs. There's SSRIs, SNRIs. There's a variety of different kind of chemical compounds that all function to alleviate anxiety. There's tricyclic antidepressants. That's a whole other system. And I think that, to me, you know, one of the things I think about is, unfortunately, medication management can sometimes be a little bit of trial and error, where you have to kind of try a certain medication based off of a person's profile, see how effective it is. If it's not, try a different one. And physicians definitely have an algorithm around what are first line versus second versus third line medications. And that's the way that sometimes you have to approach it. If there are sleep issues, I know that it's very common to recommend melatonin to help with sleep. Sometimes there needs to be a whole separate medication regimen just to support sleep. So even if you're taking an SSRI, during the day to support anxiety and address anxiety. You may need to have something like a benzodiazepine or some other type of agent that you use to help in the evenings to support kind of drowsiness and sleep. Now, conversely, if during the day whatever medication you're taking is causing you significant drowsiness, again, it may not be the right medication for that child or that person. So I do think there's no magic answer here other than to just say sometimes it's a little bit of trial and error and looking to see if you can figure out what's the best fit for the person.
Thank you so much. The next question is, if an inclusion program contributes to the worsening of a student's anxiety and has resulted in pulling a child out of school, what steps can you suggest be taken to allow for an appropriate placement? And is homeschooling an option due to anxiety?
That's a really good question, and it's one that I have talked quite a lot with parents about. An inclusion, so, you know, and I'll try not to be too lengthy in my response here, but what drives kind of classroom placement for all students who have an IEP is what's called the least restrictive environment, the LRE. And ideally, that would be to be included with one's kind of general education setting. And so an inclusion classroom can be a wonderful thing for a lot of students. However, there needs to be a least restrictive environment, but it also has to be appropriate, right? It also has to meet the qualifications of what's called a free appropriate public education, or FAPE. And that appropriateness can sometimes be subject. So if the inclusion placement is what's causing anxiety, and the anxiety is to the extent that it's interfering with the child's educational progress, there needs to be a discussion with the IEP team about a potential change in classroom placement, because it may be that this child needs to have a more restrictive environment for at least a portion of their day. The idea of homeschooling, I think, can sound like a really good solution, but my worry around homeschooling is that it doesn't very well mimic what the real world looks like, and it doesn't really provide the child the opportunity to really socialize or address some of the issues that may be most clinically important. So usually I try not to jump towards homeschooling, and instead try to work with the school district on finding a more appropriate school placement for the child, one that will allow them to feel less stressed and therefore more able and ready to learn.
Dr. Penna, can you speak on ABA as being a treatment to anxiety? Could this be effective?
Sure. So ABA is a really, really effective treatment for addressing a lot of issues in children and in adults who have autism. It doesn't specifically target anxiety, but what it can do is it can build skills that will then allow the child to be more effective in their environment. It can build language, it can build social skills. The other thing that ABA can help with is help learn strategies of how to modify the environment to enable that child to feel like they're in a more predictable, consistent environment, which that then leads to a reduction of anxiety. I think one of the things that we do sometimes encounter when I work with ABA therapists is sometimes we see significant behaviors happening in children who are having autism, and it's because they are anxious. And what we want to do is we want to use ABA methods to teach the child more adaptive ways to communicate when they're upset or anxious. So give them the words, use the PECS system, what are other skills we can provide this child to more effectively and adaptively communicate that they're distressed, so that then we can, you know, address it however it needs to be addressed.
And I know that we're running short for time, so I just have 2 more questions that I wanted to ask if we could. Are there any rating scales that you could suggest to track anxiety levels at school or at home?
Rating scales, sure. So the rating scales that we tend to use are those that need to be purchased and kind of, I think, require certain user qualification, but you could potentially do this in consultation with, you know, the school psychologist or your pediatrician. One that I use a lot is called the BASC, Behavior Assessment System for Children, 2nd edition. There's the Achenbach system or the CBCL. These are some pretty common rating scales that do assess for anxiety and that you can use to kind of periodically you know, check in over time. You can also do a more simplified rating scale if you just want to have some sort of data for yourself, where you could just put it together on your own, honestly, and put together what is the list of symptoms of concern, and then maybe create a little what we call Likert rating scale, so from 0 to 5, and then you know, over time you would just fill it out. So maybe the first item is significant separation anxiety when coming into school first thing in the morning, and then you could rate it from, you know, 0 to 5, and maybe when you're first starting out working with this child it's at a 5, but you keep giving that same question and over the months you start to see that it goes down, so now it's a 4, now it's a 3, now it's a 2. That would be another way to track that information, just kind of as informal data.
And can you just share the areas that CNNH works with, or works in? I apologize.
The locations?
Yes. Are you just New Jersey based?
No. So we have 4 locations right now, 3 of which are in New Jersey. 1 is in Pennsylvania. So the Pennsylvania location is in King of Prussia. And in New Jersey, the main headquarters is located, they're just moving actually in like the next week, from Gibbsboro, New Jersey to Voorhees, so really in the same neighborhood essentially. That's the main headquarters. There is also a location in Wall Township, and there's also a location in North Jersey, North Rutherford.
Wonderful. So Dr. Penna, on behalf of the Family Support Center of New Jersey and Autism Family Services of New Jersey, we want to thank you and the Center for Neurological and Neurodevelopmental Health for sharing your expertise today. And for everyone in attendance, we strongly encourage you to look at our website. It's fscnj.org. That's the Family Support Center of New Jersey website, where you'll find upcoming in-person and webinar sessions. Some of our future webinar topics are setting a goal to find a job, autism-related wandering and keeping our kids safe, introducing the diagnosis, building a successful transition plan, and social skills for adults and teens. You can register for free right online. And Dr. Penna, thank you again for sharing your time with everyone today. And I would encourage everyone to copy down Dr. Penna's contact information that's on the screen now. And if you have any follow-up concerns or would like a recorded version of this webinar, please feel free to contact the Family Support Center of New Jersey. Thank you again for your time.
Thank you.